the next speaker to present his case. This is Dr. Hussein Heshmat Qasim. Is professor of cardiovascular medicine with Cairo University, Egypt, and also works as a consultant interventional cardiologist in the UAE. Dr. Hussein, please.
Thank you, sir, for the introduction, and thanks for the invitation. I'm glad to be among this wonderful group of interventional experts, sharing my humble experience in this device. I'm originally from Egypt, and now I'm practicing in the UAE. And as Dr. Ashok mentioned, one of the biggest problems with complex high-risk interventional procedures is calcium. Calcium would either prevent delivering the stent, which means procedure failure, or it can result in stent under expansion, which means a failure either in the coming hours or within the coming month, either stent thrombosis or stent restenosis. So if you're running a cath lab, you need to understand what gadgets do you have as an essential item and which gadgets would you have as luxury. Because now you have many options: rotablation, shock wave, cutting balloons, scoring balloons, CSI, CTO wires, guide catheter extensions, etc. But one of them, which I really like because of its simplicity and convenience, is the OPN balloon. And I'll take you with just a short trip in my experience in this wonderful city of Fujairah. I'm talking to you now from this lovely white tower. I started a couple of years ago, and in that time, I'll show you the first case. These were the early days where we had no IVUS, no OCT, no rotablation, no cutting balloons. We had none of these. We had the OPN. And here's what we had. From the emergency, I was called for a 91-year-old male, and he's a VIP. He presented to the emergency because of 3 hours chest pain. He had PCI 18 years and 20 years ago in Germany, and we don't have any records. His diabetes, he having a stroke, mild chronic kidney disease. You can see the inferior ST elevation. So the cath lab was activated. You can see how tortuous the subclavian is, which you expect in the elderly. And you can see how miserable the left system is. Significant distal left main, probable 2 stents in the LAD. The LAD is destroyed. The circumflex is extensively diseased, and you can see the shadow of the RCA, which tells you which trouble are you heading to. And this is the RCA. You can see it's extensively diseased, and probably the only part that you can fix is this silhouette of marble of calcium. To be honest, I didn't know whether that was a stent or just a calcium. We went ahead with the regular way. We crossed with a wire, we dilated, we tried to deliver the stent, but you can see this is one of the best everolimus eluting stents. It's not delivering. And you can see why. You can see on the right side the dog boning. This is a regular NC balloon, and you can see the dog boning. Eventually, with more pre-dilatation with NC balloons, we were able to deliver a thin strut stent, 275. But because I know that this is very calcified, and his right coronary artery is the only viable vessel in the heart, and it's supplying retrograde the LAD. So there was no chance that this man, at his age and his situation, gets an acute or a subacute stent thrombosis. So after we deployed the stent, we got our OPN. It was probably the early patients who used the OPN. And as you can see here, the linear symmetric expansion of the balloon across the curve, opening the stent at 35 atmospheres. And this is the final result in 2 projections. The lesion is completely treated, and it's filling the LAD also retrograde. We were glad that this 91-year-old male went home. We sent him for surgical evaluation 2 months later. He was declined by the surgeons because of his age and asymptomatic status. He became asymptomatic after the RCA was fixed. He only came to us 1.5 years later when we had fractured neck femur. After the operation, he had a sharp rise of troponin, so we had to do a repeat angiography. And as you can see, this is 1.5 years later. The LAD circumflex are more or less the same, and see the area where we placed our stent and dilated by the OPN. It's wonderful. almost no restenosis, and filling the left system. So we had the courage of using this frequently, and as our lab evolved, now we came to have more fancy gadgets. But let's see this man, a 55-year-old male, hypertensive, history of PCI 3 years ago. He presented with STEMI, thrombolized, and came to us. And you can see the lesion in the distal RCA that was treated easily. But as Dr. Ashok said, you never underestimate. You never take it lightly. We did an OCT for this stent, and we found that there's not only in-stent restenosis, there's neo-atherosclerosis. So we went in and we placed another everolimus long eluting stent. But as you can see, the stent is not opening. So we went with the NC balloon, and again, the waist is there up to 20 atmospheres. So we went with the OPN, we went up to 40 atmospheres, and the stent is open. And this is the final result, angiographic, and with OCT, the area is more than 6. So this is a situation where there are 2 layers of stent. Using a rota or a CSI atherectomy is out of question. A third case is interesting because it shows the concept that Dr. Ashok was just mentioning. This is a lady that we received from another hospital. As you see, the age range of the patients I'm treating is a bit high. So she's an 82-year-old lady, hypertensive, diabetic. She performed PCI just 2 days ago in another city. And she came with acute chest pain, acute pulmonary edema, and anterior ST elevation. And you can see how her vessels look like. She had no radial. She had just closed the femoral with a pair close, so it was difficult to do the femoral puncture. Eventually, we did bilateral femoral puncture. We had an intra-aortic balloon because she was in pulmonary edema. And you can see how her vessels look like. And you can see here why the stent got acutely thrombosed from the colleague, because there was a chunk of calcium, and the long stent was placed without proper pre-dilatation or proper post-dilatation. So this is a situation where you have a mix of thrombus, underexpanded stent, and calcium, where shock wave will not help, rotablation will not help, and the only one would help is the OPN. We went in with the NC balloon just to establish the flow, and then you see the one nice uniform expansion of the OPN balloon at 40 atmospheres. And you see now this is the final result of the patient. The last patient is a 78-year-old lady, diabetic, history of PCI, and she presented with high-risk non-ST elevation ACS, severe chronic kidney disease, and ejection fraction of 26. And she refused surgery, and she was declined by the surgeons. And this is her LED. It's a tram line of calcium. And this tram line harbors a severe lesion in the mid-LED, and this LED is supplying the RCA retrograde. So we had to pave the way to crack the calcium just with a 1.5 millimeter burr of rotablation, and we were backed up by an intra-aortic balloon because of her poor ejection fraction and the multi-vessel status. And the nice thing about rotablation, it gives you a way. It cracks the calcium so that you're able to deliver your hardware afterwards. But it doesn't dilate the lesion, because if you look at here, the balloon, there's still an indentation and some dog boning of the balloon, to the extent that we had to put a guide liner because the rotablator alone did not do the job. So we had to place a guide liner to deliver the stent and then to deliver 4 OPN balloons. In this patient, we used 3 and 3.5 for the LED, used 4 millimeters for the left main. And this is the final result of the stents expanded in the left main and the LED, with the IVUS picture showing a minimal lumen area of more than 10 millimeters. So I hope I stick to time, and I showed you why I like this balloon, because it works across simple cath labs where you don't have all the gadgets, and with highly advanced cath labs where you have all the gadgets, you still need this wonderful piece. Thank you so much.
Thank you. Thank you, Dr. Hussain. Those were really fabulous cases. And I think we will have some questions as we go down to